Welcome, and it's my pleasure to introduce you to Toby, who's an NIHR clinical research fellow at the Institute of Psychiatry. And Toby won the British Association of Psychopharmacology Clinical Research Award last year when we could still meet people for an earlier version, I believe, of this same talk. And he's recently published a Maudsley Guidelines on dealing with physical health conditions in psychiatric illnesses alongside Fiona Cochrane and David Taylor. Toby has taken a very keen interest in the management of physical health conditions in psychiatry and used to, and I guess still do, run actually courses for trainees and psychiatrists in this area. So thank you very much, Toby, for your time, and I'll hand over to you.
Thank you very much, and thank you everyone for having me. So today we're going to be talking about something that, well, I would argue is one of the most important topics in psychiatry at the moment, which is the cardiometabolic health of individuals with serious mental illness, and in particular, people with schizophrenia. These are my disclosures. I think before we get into the bread and butter of the talk, I think it is important, it's useful to describe my sort of research and clinical journey thus far, because it sort of serves to contextualize some of the material that I'm going to be talking through. It also satisfies my penchant for looking at pretty hospital buildings from around the UK. So I did all my training, I'm afraid to say, in Oxford, and then I did my very junior jobs there as well. So I think I was one of the last trainees to work in the Radcliffe Infirmary, which is in the top left-hand corner here, which I think is now a maths department, sadly. And then rather than going straight into psychiatric training, I then went to London and did some general medical training, working at hospitals like the Hammersmith Hospital in the middle here and the Royal Brompton on the right, jobs like respiratory medicine, cardiology, renal, hematology, etc. And then about 6 years ago, I finally made the transition to psychiatry, and south of the river to the Institute of Psychiatry in the Maudsley, where I took up a research fellowship. But I also worked in a service predominantly looking after individuals with treatment-resistant schizophrenia and facilitating community access to clozapine. It was really when I made that transition from general medicine to psychiatry that my eyes were open to the significant physical comorbidity that is present in individuals with serious mental illness. I mean, to the extent where I was, the complexity was far higher in a lot of the people I was seeing in my psychiatric outpatient department than a lot of the people I was seeing at the Hammersmith and the Royal Brompton. And that really fed into a lot of the research that I've been getting into over the last few years, which is predominantly focused on that sort of mind-body continuum in individuals with serious mental illness, and really in particular in individuals with psychosis. And that's what we're going to be talking about today. This is some background that, may be a bit boring because people bang on about it so much, but I think it is important to underline that individuals with schizophrenia die roughly 15 years earlier than members of the general population, and the majority of that excess mortality is secondary to cardiovascular disease. And it is so well recognized that schizophrenia in particular, but broader serious mental illness, represents a risk factor for cardiovascular disease, that having a diagnosis of serious mental illness and schizophrenia is starting to make its way into well-established cardiovascular risk prediction tools, such as the one shown here at the bottom, the Q-risk calculation. Its most recent iteration, if you add in having a diagnosis of schizophrenia or indeed being prescribed an antipsychotic medication, it increases your likelihood of having a heart attack in the next 10 years, which is what the Q-risk 3 is used to provide. So this is big mainstream stuff, essentially. But then, of course, we have to recognize that the reasons that individuals with schizophrenia present with excess rates of cardiovascular disease and cardiovascular mortality are multifactorial. So, of course, there's lifestyle factors, poor diet, reduced levels of exercise, increased rates of smoking. Then there are illness-related factors, thinking of negative symptoms of schizophrenia impacting your ability to get out, to engage with services, or indeed positive symptoms, paranoia, impacting your ability to engage with general medical services. We know that individuals with schizophrenia are less likely to present to medical services, likely because of those illness-related factors, and so they end up presenting later with more advanced physical health conditions, which are therefore more difficult to treat. And then even more astounding and worrying in the current age is that even when an individual with schizophrenia presents to general medical services, they're less likely to get that gold standard quality of care that a member of the general population might get. And a nice example of that is that if an individual with schizophrenia presents with a heart attack to A&E, they are 10% less likely to have an angiogram and a stent fitted compared with a member of general population. And that translates into a 10% increased mortality post-MI in individuals with schizophrenia. Then we know there are antipsychotic effects, so and some other treatments that we prescribe, which are increasing cardiometabolic burden. We're going to be talking about that today. And then finally, again, something that we're going to be covering today is that there's this more of a research query than anything, but this question as to whether or not individuals with psychosis present with an intrinsic sort of risk or intrinsic metabolic dysregulation. So we're going down the lines of whether or not we think of psychosis as more than just a brain disorder, but actually a multi-system disorder. So there are three main objectives to my talk. Number one, I'm going to be presenting some data and presenting the case that individuals with psychotic disorder may present with intrinsic metabolic dysregulation that sort of puts them further down the line towards developing things like diabetes earlier than members of the general population, even if you take out the sort of confounds of lifestyle and medication. Then we're going to be talking about the actual something that might be a little bit more clinically relevant, which is that the specific cardiometabolic effects of some of the treatments that we prescribe, both indirectly via metabolic dysregulation, but potentially also directly via direct effects on the heart. And then finally, we're going to be thinking, how with that information taken on board, we should be informing our clinical practice and our prescribing practice. And in order to do that, I'm going to be touching on some material from a book that we've just had published, which is essentially a guidance on how to manage physical health conditions in individuals with serious mental illness. So, number one, is psychosis associated with intrinsic metabolic dysregulation? Well, this is not actually a particularly original question. So Henry Maudsley came up with this idea back in the 19th century. And if anyone spent any time at the IOP, you will recognize this statue. It sits in the stairwell. And about 4 years ago, I decorated that statue with some Mars bars to honor Sir Henry Maudsley's observation that, as he says, diabetes is a disease which often shows itself in families in which insanity prevails. Not a particularly politically correct term, insanity, but we believe that he's referring to individuals with schizophrenia. What's interesting is that Maudsley was making this comment in an era that was pre antipsychotics and in an era where diets were less diabetogenic, if you will, and yet he was still observing that there was potentially some increased risk of diabetes in individuals with serious mental illness and probably schizophrenia. So the question is, well, is he right? Well, we know in chronic schizophrenia that rates of diabetes are 2 to 3 times more likely overall. Indeed, in people with really established chronic disease, you're looking at sort of a prevalence of 60 to 70% in some studies. But of course, that may well be just simply related to lifestyle factors and, of course, the medications that we prescribe. So one way to sort of try and shed a little bit more light on this question is to look at individuals where those confounds of lifestyle and medication are limited, and that's to look at individuals right at the onset of illness, so first episode of psychosis, and those who are antipsychotic naive. And that, to a certain extent, has been done already. So Alex Mitchell from the University of Leicester did a study looking at the prevalence of diabetes in drug-naive first episode psychosis. And actually, he showed there was no difference in the prevalence between patients and the general population. The problem with those sort of prevalence studies, however, is twofold. Number one, we know that individuals with psychosis, with schizophrenia, are less likely to present to general medical services. So there's a risk of underreporting in those things, and it just thus confounding any form of prevalence study. But also, those sort of studies tend to neglect to recognize that the development of diabetes is on a continuum, but it's up to a decade, really. And over that 10-year period, you have a period which this diagram here is showing of increased insulin secretion because you're eating more Mars bars, sugary stuff, and you're having to, in order to keep glucose homeostasis, you're having to increase your insulin secretion from your beta cells. But as a result of that, you have increased peripheral insulin resistance. And eventually your pancreas can't keep up, and your fasting glucose and your postprandial glucose starts to rise until you meet that arbitrary line in the sand that the World Health Organization, NICE, American Diabetic Association have used to give you a diagnosis of diabetes. So that's happening over a period of 10 years. And if you think that individuals with first episode psychosis are typically relatively young individuals, there's a chance that those individuals, they may be further down the line towards developing diabetes, but they may not have yet actually met that line in the sand for a diagnosis of diabetes. So the prevalence studies might suggest that there's no difference between patients and controls, but actually in terms of absolute numbers, there may still be a difference. So it's essentially looking at this region here in that time period before you develop diabetes. So we set out to do a very simple meta-analysis, essentially, which was to essentially look at and see if there was any difference between patients and controls. So patients with first episode drug-naive psychosis and controls in terms of markers of glucose homeostasis. And what we mean by that is levels of blood glucose, blood insulin, and insulin resistance, essentially. And this is a paper that we published in JAMA Psychiatry in 2017, which essentially performed that meta-analysis. For those of you who aren't au fait with a pairwise meta-analysis, all that involves is taking a series of studies that are all asking the same question: is X higher in one group compared with another, and combining those studies to give an overall effect size that summarizes all of those findings. And you end up with a forest plot, which shows all the individual studies, which are the number of horizontal lines here. And if you're to the right of this vertical line, then you have elevated, you have elevation of a given parameter in patients. And if you're to the left of the line, it's elevated in controls. And then the diamond at the bottom shows the summary effect size for that particular question. And so what this slide here is showing is that individuals at the onset of psychosis who are drug naive have elevated fasting glucose compared with controls. And then when you look, it's a modest effect size, but still significant. But if you look at the gold standard measurement of glucose dysregulation, the oral glucose tolerance test, fewer studies, but a more impressive effect size with greater significance. So evidence of glucose dysregulation. And when you look at fasting insulin and insulin resistance, the finding is maintained. So glucose dysregulation in first episode psychosis. Now, a criticism of this study is that people, and we factored this in when we experienced this when we had the paper in review, was that, okay, well, we've tried to manage the confounds of lifestyle and diet and exercise and antipsychotic use as much as possible, but we know that in the prodrome, there are individuals who, we know that lifestyle factors are still an issue. And so we still may simply be confounded by that this is just a difference in lifestyle factors between patients and controls. So in order to try and delve down a little bit deeper and to make our results a little bit more robust, we did some sensitivity analyses where we only looked at studies where patients and controls were matched for body mass index, matched for diet and exercise, matched for ethnicity, because as we know, certain ethnic groups are more vulnerable to developing diabetes than others. And where the data was available, the results didn't change. There was evidence of glucose dysregulation in patients compared with controls. So the take-home message is, regardless of what you think about mechanisms, we know that when an individual at the onset of psychosis sits down in front of you in clinic, they are, on average, further down the road towards developing diabetes compared with a member of the general population. And so we would argue that we should be considering diabetes right from the onset of psychosis, and not simply when you're thinking about prescribing an antipsychotic and monitoring thereafter. So Henry Maudsley looked at, was one of the first people to think about glucose, but what he didn't think about was cholesterol. And we decided to take things a little bit further from the first meta-analysis that we performed, looking at glucose and insulin, and we decided to ask the question, do exactly the same meta-analysis essentially, but looking at lipids. And if the critics of the first study were correct, you would assume, and in the sense that you're blaming the findings of the first study simply on diet and exercise, essentially, then you would expect cholesterol levels to be raised in patients with first episode psychosis compared with healthy controls. But we actually showed the opposite. What we showed, and again, this is a meta-analysis simply looking at cholesterol levels in patients with first episode psychosis compared with healthy controls, drug-naive first episode psychosis. And actually what we showed is that total cholesterol was reduced in patients with psychosis, and LDL, so-called bad cholesterol, was also reduced in patients with first episode psychosis. So this was relatively surprising. So that raised cholesterol that you typically see in people with chronic established schizophrenia you do not see in first episode psychosis, and therefore this should be a secondary and preventable phenomenon. The question is how do you marry those twin sort of take-home messages of increased insulin resistance in patients with first episode psychosis versus individuals with reduced cholesterol? Because it doesn't really make sense, does it? So one thing that we're looking at, and this is very much going into the realms of research now, is that we tried our best about 2 years ago. I worked with a Cambridge research fellow, Emmanuel Osimo, on this. We tried our very best to do it. We did the largest meta-analysis to date, looking at levels of pro-inflammatory cytokines, inflammatory mediators in psychosis, in drug-naive first episode psychosis compared with controls. And we actually tried our best to, in some ways, demonstrate that there wasn't a pro-inflammatory state in psychosis, because a lot of the studies are confounded by the fact that a lot of the studies looking at cytokines in first episode psychosis are confounded by the fact that they don't match very well patients for smoking and BMI, all those things that we know are pro-inflammatory. But whatever we did, we couldn't actually, the results were pretty robust in the sense that we couldn't, there is a pro-inflammatory state in individuals with first episode psychosis, however which way you look at it. So raised levels of IL-6 and TNF alpha, interferon gamma, etc. And my question is whether or not that sort of paradoxical metabolic signature of insulin resistance but reduced cholesterol can be explained by inflammation, essentially. Because, and the reason for that, is that if you look at typically the sort of prototypic pro-inflammatory conditions such as rheumatoid arthritis or lupus or psoriatic arthritis, these conditions do actually present with a similar metabolic signature, which is one of insulin resistance and reduced levels of cholesterol. And the reason for that is that these pro-inflammatory cytokines obviously have lots of different jobs around the body. And some of them, such as IL-6, TNF alpha, are adipocytokines, so they're fat signaling molecules as well. And not only do they increase insulin resistance, as shown by this sort of figure here in patients with rheumatoid arthritis, you see as inflammation is going up, your insulin resistance is going up, but they also suck cholesterol out of the blood, and therefore it looks like you've got lower cholesterol levels. So, and that's exactly the same metabolic signature that you see in individuals with first episode psychosis. And so one of the things we're now looking at, we're running Oliver House is the chief investigator of this study down in South London, is we're looking at the notion of whether or not you can manipulate inflammatory processes in first episode psychosis. And we're using a monoclonal antibody called natalizumab, which targets brain resident macrophages to do this. What I'm very interested in is whether that metabolic signature can be used as either a marker of psychosis, treatment response, or actually can correlate with symptom response in these individuals. That's very much a research question, but I think it's useful to let you guys know what sort of things we're looking at the moment. So some evidence that there might be intrinsic metabolic dysregulation in first episode psychosis, but let's actually think about the things that we know are a real problem in psychosis, and that is the role of antipsychotics in cardiometabolic dysregulation. Before I start ranting about antipsychotics, I think it's important to recognize that they're actually pretty effective treatments. So we're going to consider the good, the bad, and the ugly of antipsychotics. We know that antipsychotics are effective treatments. And Stefan Leuk, in a really, I think, an elegant study published in 2012 in the British Journal, demonstrated this, where he took a number of treatments for general medical conditions and compared their effects, their efficacy essentially, with a number of psychiatric treatments. And that's shown in this figure here on the right, where essentially the white blobs represent the effect size magnitude for general medical treatments of things like hypertension, raised cholesterol, etc., migraine. And then the blue blobs represent all the general, the psychiatric treatments. And those are higher up the axis you are here, the more effective the treatment is. And essentially, psychiatric drugs do pretty well across the board in terms of a comparison with with non-psychiatric medications. Circled here in red is the effect size magnitude for antipsychotic efficacy in preventing psychotic relapse in schizophrenia, and it's more effective than the majority of all drugs available throughout medicine. Effect size of 0.9, a large effect size. So these are effective treatments. The other thing is that we know that if you have schizophrenia and you're prescribed an antipsychotic, you live longer than an individual with schizophrenia who isn't prescribed an antipsychotic. So Jari Tihonen from Finland has been doing an awful lot of work on this over the years. He published a seminal paper about 10, 11 years ago, I think it was in The Lancet, looking at patients over time and looking at their mortality rates, depending on whether they were prescribed an antipsychotic or not. And he published an updated version of this just this year in World Psychiatry. So, and he's looking at about 60,000 individuals with schizophrenia over a period of 20 years and comparing their mortality or their survival over that time period, depending on whether they were prescribed an antipsychotic or not. So you have this Kaplan-Meier curve here, where the light gray line represents the group of individuals who were treated with antipsychotics, and the black line represents the individuals who were not treated with antipsychotics. And you can see at any point in time, essentially over that 20-year period, that if you're prescribed an antipsychotic, your survival probability is higher than if you're not. And I hope you can see the forest plot on the right. It may be obfuscated by some of the Zoom pictures, but essentially all that shows as a forest plot is it's comparing your versus no treatment at all, your hazard ratio for death for all the different antipsychotics that you can prescribe. And essentially, you'll have to take my word for it if you can't see it, but it doesn't matter which antipsychotic you are prescribed, you will live longer if you're prescribed an antipsychotic compared with no antipsychotic at all. So antipsychotics are effective and you live longer if you have schizophrenia if you take one, on average. But we know that certainly some of the second generation antipsychotics are associated with can be associated with pretty severe metabolic dysregulation, increasing likelihood of having diabetes, raised cholesterol, hypertension by 2 to 3 times over the entire sort of population. And that translates into that figure that I started off this talk with of, excess cardiovascular mortality in patients with schizophrenia, and that excess mortality of 15 years, the predominant cause of which is cardiovascular disease. Now, I've given you some slightly conflicting statements there, I suppose, in the sense that I've said that if you have schizophrenia and you are prescribed an antipsychotic, you will live longer. But at the same time, I'm saying, but if you are prescribed an antipsychotic, then your risk of cardiometabolic disease is increased, and you are at increased risk of dying of a heart attack or stroke. So how do we marry those two sort of contrasting statements? And I'm going to try and demonstrate that through this figure here. So this is just simply a very basic schematic, which is showing the life expectancy of a member of the general population in the blue line, compared with the life expectancy of an individual with schizophrenia in the green line. Now, if we give that individual with schizophrenia an antipsychotic, then life expectancy increases. And we think that's because of reductions in death by suicide, death by misadventure, and probably better self-care over a period of their life in terms of engagement with physical health services, etc. But with that antipsychotic, you are increasing cardiometabolic risk. So you are at the same time losing some years of life. But the argument is that you are gaining more years than you are losing. So you are still getting a net gain in overall in years lived. And the priority for psychiatrists, I would argue, is how do we minimize that loss and maximize the net gain in terms of years life. So getting the benefit from the treatment without the negatives. And if we feel that cardiometabolic disease is a consequence of antipsychotic treatment, and that is contributing to that loss of life, then the argument is we should probably, where possible, be using treatments with fewer cardiometabolic side effects. But then the question is, well, which ones do we choose? And so that's what we set out to do in this network meta-analysis, which compared antipsychotics based on their propensity to cause cardiometabolic dysregulation. Now, for those of you who aren't au fait with network meta-analysis, I'm going to try and give you a crash course in interpreting them or explaining how we do it. So in an ideal world, if we wanted to compare a number of treatments, either in terms of how effective they are or their side effect profiles, we would simply do a randomized controlled trial with a number of different arms, and you would compare them that way. But of course, with conditions such as schizophrenia, which has upward of 30 different treatments available, it's just logistically impossible to do such a study, or it would obviously cost an absolute fortune. So the only way to do it is statistically, essentially, by comparing studies across the board using network meta-analysis. Now, I described to you earlier about how you do a simple pairwise meta-analysis, which is simply a series of, is collecting a number of studies that are all comparing two things, all comparing the same thing, which then gives you a summary effect size for those studies. So a series of direct comparisons. So in this figure here, you have you might have a series of studies that are comparing drug B with drug C, and that's a series of direct comparisons, and that gives you a simple pairwise meta-analysis. Now, network meta-analysis also performs direct comparisons. So you might have a series of studies that are comparing drug A with drug B, and a series of studies that are comparing drug C with drug B. But there may be no studies out there that have ever compared drug A with drug C. But what network meta-analysis allows you to do is it allows you to estimate the difference between drug A and drug C based on the fact that they have a common comparator, in this case, drug B. So you have a series of direct comparisons and indirect comparisons. And you can use that to rank drugs based on their efficacy or their side effect profile, which is exactly what we did. So we set out to look at changes in weight, body mass index, and all the different metabolic parameters that you choose to think of in individuals with schizophrenia who are treated with an antipsychotic or a placebo in a randomized, had to be a double-blind randomized controlled trial for acute treatment, so a median time period of 6 weeks. And the primary objective of the study was to rank those drugs based on degree of change in those metabolic parameters. We also actually had two other objectives, we wanted to delve down a little bit deeper. Having ranked the antipsychotics, we also wanted to see whether or not we could predict if there were any baseline predictors that would determine vulnerability to antipsychotic-induced metabolic dysregulation. For example, we know that in the general population, you are at increased risk of metabolic disease if you're older or if you are overweight. So we wanted to see if that was a similar risk factor in people with antipsychotic. For people who are prescribed an antipsychotic. And then the final thing that we wanted to do was to see if there's actually a relationship between change in metabolic parameters and change in symptomatology. Essentially, as you get better, do you get fatter in the crudest of senses? So those were the three main objectives. We managed to gather data on about 100 randomized controlled trials, 30,000 patients thereabouts. And we got data on 18 different antipsychotics. Unfortunately, the majority of those were second generation antipsychotics. And the reason being is that the majority of the studies looking at first generation antipsychotics didn't collect data on metabolic parameters because it wasn't seen as an issue back in the day. But it is a limit of the study, admittedly. What I'm going to show you now is a series of forest plots, which is essentially comparing the magnitude of metabolic change for all the different antipsychotics compared with placebo. So if you are to the right of this vertical dotted line, then you have an increase in a given metabolic parameter compared with placebo. All right. And the effect size, the form of the effect size is mean difference. So essentially, for example, in this forest plot, you can see along the bottom, you have 0, 2, 4, and actually, because it's mean difference, that means, and because we're looking at weight, that means that this translates into 2 kilogram increase, 4 kilogram increase in weight over 6 weeks. So here on this side, we're looking at change in weight and change in body mass index with antipsychotic treatment. And, some of the results are really not very surprising. Essentially, and I'm going to spoiler alert, as we would expect, drugs like quetiapine, olanzapine, clozapine are pretty bad. And really, the only thing that was sort of eye-opening was the magnitude of change that was associated with treatment with some of these drugs. So, for example, if you take olanzapine or clozapine for 6 weeks, on average, compared with placebo, you're putting on 3 kilos of weight, and your BMI is going up by 1 kilogram per meter squared. So not particularly, surprising, but, it's still a pretty eye-opening figure. With the same things that as we expected, increases in total cholesterol with drugs like olanzapine, quetiapine, and clozapine. But things started to get a little bit more interesting when we started to look at LDL cholesterol, because whilst again you had the usual suspects causing rather large increases over a relatively short period of time, some drugs started to outperform placebo in terms of their metabolic changes. So, for example, in the case of LDL, so-called bad cholesterol, the partial agonist cariprazine, so a drug like aripiprazole, for example, actually was associated with reductions in LDL cholesterol compared with placebo. And with HDL cholesterol, so the good cholesterol, these are more subtle changes, but significant nonetheless. Again, the partial agonists, aripiprazole and brexpiprazole, were associated with significant increases in good cholesterol compared with placebo treatment. With triglycerides, no surprises per se, but again, this comes back to my previous comment that some of the magnitude of changes were really quite astounding. So after 6 weeks on clozapine, your triglyceride levels are increasing by 1 millimole per liter on average. Now, to put that in context, the upper limit of normal of a triglyceride level is 2 millimoles per liter. So you're adding another 1 on top of that. And if you look at previous cardiovascular risk prediction studies, for every 1 millimole increase in triglycerides in your blood, depending on whether you're male or female, your cardiovascular risk increases between 30 and 70%. So these are really large changes. And then finally, looking at glucose, again, the usual suspects associated with large increases in glucose over 6 weeks. But again, there are drugs that are outperforming placebo, specifically lorazepam, which was associated with reductions in glucose compared with placebo treatment. So the take-home message from this part of the study was that, surprise, surprise, olanzapine, clozapine, but also quetiapine, etc., basically anything that ends with pine is associated with comparatively worse side effect profiles. But we have those 5 drugs that were either preferably had improvements in metabolic parameters or showed relatively benign metabolic changes over that time period. And those drugs were ABC, so the 3 partial agonists, aripiprazole, brexpiprazole, and cariprazine, and then lorazepam and ziprasidone. And so the argument that we made in the paper is that all things being equal, of course, there are other things you have to take into account in terms of symptom response and other and other side effect profiles, but all things being equal, we should ideally be choosing these drugs preferentially in the treatment of schizophrenia. And we produced this heat map, which really I've used in clinical practice. Stuck it on the, well, this in the days pre-COVID when I was able to see people in clinic, but essentially show a heat map of the degree of metabolic dysregulation that you might get with different antipsychotics, and you can work collaboratively with a patient sitting in front of you. And essentially, if you can see all the different metabolic parameters on the top, and you can see all the different antipsychotics along the left-hand side, and essentially the more red the square is, the greater degree of dysregulation you get with a given parameter. And so if you've got someone who is already diabetic, for example, and say, well, I don't want something that's going to potentially impact my glucose, then you can go and you can look at, say, well, look, amisulpride is pretty good, or lorazepam is pretty good, and you can choose treatments. You can work together using this figure. But let's delve a little bit deeper. This is a pretty grandiose title. I don't think we're really we're talking about personalized medicine here, but we did try to some extent, using this large data set, to try and pick out whether or not you could see predictors of degree of magnitude of metabolic dysregulation associated with antipsychotic treatment. So as I said before, we looked at things like age, gender, ethnicity, baseline body weight. So are there physiological parameters or demographic parameters that can predict magnitude of metabolic dysregulation? And it seems that you can. So what we showed is that if you were overweight at baseline before the study, or if you were male, you were at risk of a larger increase in glucose over the study period. So that's shown in this graph here. As your baseline body weight is increasing, your fasting glucose is going up by a greater degree over the study period. You might not be able to see this, again, obfuscated by the Zoom faces, but again, the greater the proportion of males in the study were associated with greater magnitude of glucose increases over the study period. And we don't have the figures to show you here, but also what we showed is that if you were of non-white, non-Caucasian ethnicity, you were at greater vulnerability to developing a greater magnitude of cholesterol increase in the blood. Here is that it does seem to be some predictors, some physiological demographic predictors of magnitude of metabolic dysregulation with antipsychotics. And again, that feeds back into, well, which drugs should we be using preferentially in certain individuals? Well, if you've got someone who's male, overweight, of non-Caucasian ethnicity, then you might again be using that, factoring into your decision-making process of which antipsychotic you're going to be using. Unfortunately, we weren't able to get any more granular with regards to ethnic groups, because the data just wasn't presented by the clinical trials. And finally, we wanted to pick out as to whether or not there was a relationship between symptom change and metabolic change over time with antipsychotic treatment. So in this figure on the right, you're showing on the x-axis the effect size magnitude for change in total symptoms, so PANSS total, BPRS. And then on the y-axis, you've got the mean difference, the change in weight. And as you can see, very interestingly, is as your symptoms improve over time, your weight goes up. as yours. And you may, again, I apologize if so, you may not be able to see it. You're gonna have to take my word for it. You see exactly the same thing with your body mass index. So as your BMI goes up, your weight is going up. With your bad cholesterol, as your symptoms improve, your LDL cholesterol is going up. And with your good cholesterol, very intriguingly, as your symptoms improve, your good cholesterol is significantly reducing. So metabolic dysregulation does appear to be associated with symptom improvement. Now, we're not arguing here that metabolic dysregulation is a prerequisite for symptom improvement. In some ways, these results are not particularly surprising. We know that some of the more effective treatments available to us, olanzapine and certainly clozapine, can be associated with pretty dire metabolic dysregulation. But we also know that those drugs are pretty dirty drugs, so they have the potential for a series of off-receptor actions, some of which may be contributing to their superior efficacy, but some of them may also be impacting things like appetite, metabolic metabolism, which may be contributing to their metabolic profile, which actually has nothing to do with their ability to improve symptoms. But the summary of the findings from the network meta-analysis is marked variations, surprise, surprise, in the metabolic side effects of different antipsychotics. We identified 5 treatments that we thought were superior to others: ABC, aripiprazole, brexpiprazole, cariprazine, and then lurasidone and ziprasidone. We identified vulnerable populations that might be more vulnerable to metabolic dysregulation. But we also highlighted that any decision to preferentially use those treatments with more benign metabolic side effects may be associated with a reduction in clinical improvement. So you may ultimately, even if you do try them first time, be forced to move on to more metabolically active treatments, which actually is sort of what happens already in the treatment of schizophrenia, because ultimately, if the drugs aren't working, then you're going to move on to clozapine anyway. I've talked briefly about the sort of indirect effects of antipsychotic treatment on cardiac disease via metabolic dysregulation, but I'm going to very, very briefly talk about the potential for cardiotoxicity, direct cardiotoxicity of antipsychotics. We know there's some preclinical evidence of this. So if you mess around with dopamine signaling, you have increased myocardial fibrosis and inflammation in rats, mice, and rabbits. So, for example, you have D3 knockout mice here. So you have, you have wild type mice. This is slides of the myocardium of mice that have been over time. You've got the wild type mice here, and you can see in the interstitial space, you can have this black substance here, which is collagen, is building up over time. So you have a 2-month-old mouse in slide A, B, and C up to 2 years, and you can see the collagen building up over time. But if you have a D3 knockout mouse, you can see that at 2 months, the level of collagen deposition is similar to a mouse, a wild type mouse at 2 years. So you're increasing vulnerability to fibrosis of the heart, and that translates into mortality as well with this Kaplan-Meier curve. And then again, if you sprinkle haloperidol onto some cardiac myocytes, you essentially induce a state of that you would normally see in pressure overload in heart failure. And then at the bottom, I think these are actually rabbits. You can see rabbits that have been given increased doses of clozapine over a period of 3 weeks, and there is a dose response curve of increased evidence of myocardial fibrosis, inflammation, and oxidative stress, depending on what dose of clozapine you're giving. So there's evidence of cardiac toxicity in preclinical studies. The question is it present in humans as well? Well, along with Emmanuel Osimo from Cambridge, we did a first ever cardiac MRI study in humans, in individuals with schizophrenia. And what cardiac MRI allows you to do is it allows you not only to get really accurate measures of cardiac structure and function, but it allows you to essentially measure fibrosis and inflammation. So in this figure here, you're looking top down onto the left ventricle of the heart, and you can see the wall of the left ventricle, and you can get a heat map, which is shown in this sort of purple. You can see this purple circle here on the right, of how quickly the heart is relaxing with every myocardial contraction. And essentially, the more hot the wall looks, so the more red or yellow, the slower the heart is relaxing over time. And the thing that slows down myocardial contraction is one of two things. Essentially, it's either collagen, so fibrosis, or water, inflammation. And what we showed We compared a cohort of individuals with schizophrenia and healthy controls. You had to be entirely healthy from a cardiovascular perspective to enter into the study, so no cardiometabolic disease at all. And patients were matched for age, sex, smoking status, body mass index. So essentially, we tried our best for the only difference between the two groups to be a diagnosis of schizophrenia and the fact that those individuals were prescribed an antipsychotic. And what we showed is that relaxation time was prolonged in individuals with schizophrenia compared with healthy controls. In other words, it's a marker of myocardial fibrosis and or inflammation. And when you looked more broadly at cardiac structure and function, what you showed is the hearts of individuals with schizophrenia were smaller, essentially, and they basically looked a bit older than individuals with the general population, which is in keeping with a fibrotic process. So there's some suggestion from this data that antipsychotics may be having a direct effect on the heart, but of course, further studies required in this, and I certainly wouldn't take that as gospel at the moment. So just to tie up the talk, I just want to think about how we can use the data that I've talked about today to inform our prescribing practice. Now, I was lucky enough to be part of a Lancet Psychiatry Commission that was published last year, led by Joe Firth, who was in Australia at the time. I think he's back in Manchester now. It's essentially looking at how can we improve the management of physical health conditions in people with serious mental illness. And we came up with a number of different objectives and key initiatives for the field. And some of those I put here in terms of a need for greater integration of physical and mental health care, improving referral pathways, get greater improving access to lifestyle interventions, and of course reducing the long-term side effects of psychotropic medication. And then as I mentioned last week, we published this book, the Maudsley Guidelines for Physical Health, which I hope has addressed a number of those issues that were highlighted by the Lancet Commission. This is a text that I actually had the idea for rather selfishly. Is when I started at the Maudsley, and I was concerned that I was starting to forget all my general medicine. And also people were starting to come to me asking questions about general medical complaints in the serious mental illness population. And I didn't know all the answers. And so I thought, and I couldn't find a resource that was giving me all the answers. So I approached David Taylor, and we decided to put together this book. It is a rather large text. And it essentially is designed to be read by the psychiatrist or a general practitioner, anyone who's looking after individuals with serious mental illness. And it's designed to improve the practical skill set of those individuals in terms of managing physical health conditions in people with serious mental illness. And it covers most, I hope, medical complaints that you can see in individuals with serious mental illness. So there are about 89 chapters, probably cover about 130 different complaints. It's got an awful lot of authors, 125 authors from across the world of medicine, surgery, pharmacists, physiotherapists, occupational therapists, dietitians, etc. And here's a selection of the authors to whom I'm gravely indebted for giving up their time and expertise over the last few years. The book itself is divided into 15 sections, broadly on organ system. And then if we look at 4 of those in a bit more detail, each section is then subdivided into mini chapters, which are, cover a particular presenting complaint or a particular illness. So for example, the cardiology section is divided into chapters on a fast heart rate, slow heart rate, high blood pressure, low blood pressure, etc. And then each chapter is designed to be really succinct, short, algorithmic where possible, diagrams, etc. We define the complaint, define common causes in the general population, common causes in patients with serious mental illness. And then it really very simply talks about what you should be doing in terms of history, examination, and investigation for a given condition. And then it details when should you be worried. And then if you are worried, who should you be talking to in terms of medical colleagues, surgical colleagues, and what information should you be including in a given referral. And then for those individuals who don't necessarily need a referral, it's talking about non-pharmacological, pharmacological management that you might consider starting yourself either in an inpatient unit or even in an outpatient unit if you have one of your patients who isn't necessarily engaged with their primary care service and you may be the only doctor who's seeing that individual. So just very briefly show you as an example, the obesity chapter, which was led on by a Japanese psychiatrist, Yuya Mizuno. And you can see the page of the chapter here. You have to have incredibly good eyesight to be able to read that. But essentially, running through it very briefly, this is an example of how we define obesity, how you can measure it simply in clinic, how you can assess obesity and associated metabolic dysregulation over time in people who are instigated on psychiatric treatments that we know are associated with physical with metabolic dysfunction. I'm not just talking about antipsychotics here, but certain mood stabilizers, antidepressants, etc. And then crucially, it's talking about what do we do about it. So I've actually started using some of this material already because I had privileged access before publication, but using, for example, this box to the left here, which is simple dietary advice that you can provide to individuals in clinic. I'm not saying you have to read through it with the individual, you can literally just give it to the individual. So because in an ideal world, of course, if you have someone who's overweight, you would refer them to the dietitian. But often that can take ages if you have a dietitian at all, but often that can take ages, and maybe that individual then doesn't end up going to see the dietitian. So this might be your one opportunity to be able to instigate some form of lifestyle intervention. So pre-COVID, I was giving out copies of this, printout copies. In the era of video consultation, I can email it over to that individual, get care coordinator to do that for me. And then there's other practical tips that we have regarding exercise as well, and tips about alcohol, smoking cessation, etc. And then taking things one step further, we're talking about rationalization of psychiatric medication. So this is a figure that was actually just taken from the network meta-analysis that we used, and we essentially converted it into the for the chapter in the book. And so thinking about, well, if you are starting someone on an antipsychotic medication, should I really be using olanzapine? Should I instead be using one of the ABC, etc. drugs? Or if you're receiving someone to your service, maybe from an inpatient unit who's been established on a drug that's pretty metabolically active, should you be thinking of switching them over to something which is a bit more metabolically benign? If, despite all your efforts, lifestyle, medication rationalization doesn't work, we talk about different treatments that you can prescribe alongside antipsychotics, which are associated with reductions in weight, such as metformin prescription. And then if that doesn't work, then we talk about bariatric surgery, indications in the UK, but also evidence from other patients with serious mental illness, fairly good evidence that it's an effective intervention in people with bipolar disorder, for example. And we run through how you might arrange getting someone seen by a bariatric surgeon. And finally, it's all summarized as hopefully with most of the chapters, with a nice simple summary algorithm and signposting to complementary chapters that you might think about using in people who are obese. So chapters about high blood pressure, raised cholesterol, physical activity, etc. So I think I'm just about on time for some questions, but just before we get into questions, just a quick summary of what we've been through today. We know that cardiovascular disease is the biggest killer in people with psychosis. We know that metabolic dysregulation is present right from the onset of the illness, although whether or not that's an intrinsic issue or a lifestyle issue remains to be determined. Surprise, surprise, we know that antipsychotics differ in terms of their propensity to cause metabolic dysregulation, and some people appear to be more vulnerable to metabolic dysregulation with antipsychotic treatments. There is the potential for antipsychotics to be causing direct cardiac toxicity, but that remains very much a research question, something that we're going to be looking at over the coming years. But in the meantime, as clinicians, I would really argue that being metabolically minded with our prescribing should really be a cornerstone of our practice. A quick thanks to all of the people I've worked with over the years, Oliver Howes I've worked with for the longest time period, but also the funders, MRC, welcome. It's been absolutely fantastic. And of course, all the writers of the book. And thank you to you guys for listening. Any questions?
Thank you so much, Toby. That was a fantastic talk. Thanks again. That was absolutely fantastic. And I think your guidelines book is going to be quite a game changer in the psychiatric clinic, because I think there's a lot that we get stuck on because we either don't have the expertise or the confidence to manage ourselves, and trying to refer people on to specialities or even to get GPs to follow up our patients' physical needs is really quite difficult.
I think I appreciate you've got questions, but I think to follow up on that, it's also some of these individuals are incredibly complex, and the medics are often not sure what to do. Using examples of complications of antipsychotic treatment, clozapine, neutropenia, benign tachycardia, what do we do? Often, if you don't have experience in it as a medic, the guidance is unclear as well. So that was one of the other objectives of this book, was to try and have a consensus on what you do with some of these complications.
Okay, fantastic. So we've got a first question from Julia Deakin. So Do you think clozapine is underprescribed in the UK? And she apologizes for not being able to ask in person because her tech isn't working.
All right. Hi, Julia. Well, we know it's underprescribed. We have data both locally but also nationally. Local at SLAM, we've looked at it quite in some depth over the years, and we know that if you define treatment-resistant psychosis as someone who's, rattled through 2 antipsychotics at an adequate dose, adequate duration, we know that a huge proportion of individuals are not then being offered clozapine, and you have cases of people having 4 or 5 different trials, polypharmacy, and so yes, there is a risk of underprescribing. And I see you've had a follow-up, Julia, saying you're worried about being metabolically minded exacerbates this. I hear what you're saying. I think, again, and this is why I was quite keen in my talk to recognize the pros and the cons of treatment, and recognizing that, the important take-home message, if I ever give a talk about clozapine, is, that if you live longer if you're taking clozapine, and actually your cardiovascular mortality is reduced if you take clozapine, and that's a really key take-home message for clinicians. And I think, and again, it's about, but I don't think we can ignore the fact that, okay, you live longer if you take clozapine, but you are probably still losing years of your life because of the metabolic dysregulations associated with it. So it's all about that net gain. And so I hear what you're saying about, mitigating that risk is about informing individuals of the risks and the benefits, and being aware that clozapine is an excellent treatment, and you live longer if you take it. But by being metabolically minded, we can potentially support people living even longer. I hope that sort of answered your question to some degree.
Thank you. We've got a question from Emilio. What can we do to actually, close that increased mortality gap? What seem to be the barriers?
Hi, Emilio. So that's a very good question. I think there have been a few efforts over the years to target things like lifestyle factors, which through research studies, so thinking of the Primrose study, for example, and there's been the Change study in Denmark, but which haven't been particularly successful, unfortunately. And I think that serves to underline that it's really tough in this patient cohort to instigate changes in physical health that are beneficial. If I'm being honest, I think one of the major things is smoking cessation, actually. I appreciate I've just given a talk that's entirely directed towards cardiometabolic disease and the role of antipsychotics. I think if we could reduce smoking rates in our cohort, I think we would see improvements. But yeah, the failure of a narrowing in mortality gap is worrying, and I think that probably reflects the fact that in society, people at the higher end of social strata tend to have access to improvements in physical health services before individuals lower down, and as we know, lower socioeconomic class is associated with schizophrenia, and I think that probably contributes to that sort of steady mortality gap, or if you read some papers, it's actually worsening. But yeah, smoking, I think, is a key one, but also it being a concerted effort. And I think that was one of the reasons why we wrote the book, was to try and get people all singing off the same hymn sheet to try and improve things.
So there's a question from Shahid, which I don't think you have very much of a choice as to how to answer. Do you think there should be more physical medicine training for psychiatrists?
I was doing a grand round at the Institute of Psychiatry last year, and I rather flippantly made the argument that maybe a psychiatry training should be dual accredited with general medical training or GP training. And it was met poorly by the audience, as you can imagine. I don't think you may necessarily have to go that far, but I would actually argue you should go beyond psychiatry. I think it should be from medical school, but also nursing training as well. It was reflecting on my talk, when I made the transition from general medicine to psychiatry, so I had spent years doing general medicine, doing my membership exams, there had been no mention of physical comorbidity and serious mental illness and the burden of it during any of that training. It was completely novel to me. So I think making people aware right from the beginning also will do something to challenge that stigma of getting poor treatment, from general medics towards individuals with serious mental illness when they present to services. But yeah, I think in the meantime, and I do offer some of this training, is about but it's all rather retrospective. We're being reactive rather than proactive, to use a sort of rather corny term. But I do think I would argue in the membership exams, for example, we should potentially be focusing more on physical health management. So yes, in the short answer.
Okay, Jorge, would you like to come in for your question?
Hi there, fantastic talk. I thought I'd just do a question in person because it's very tough in an empty room. I'll just ask a little bit about the metabolically minded prescribing. So the Tihonen study does show that people live longer with clozapine in spite of whatever disadvantages with regards to metabolic syndrome that brings compared to antipsychotics that have a better metabolic profile. So I was interrupted about 4 times during your talk, so apologies if you mentioned this already, but is metabolically minded prescribing could it be more in line of starting antipsychotics together with something like metformin and perhaps a statin and perhaps an ACE inhibitor? Should we be heading in that direction rather than going more for aripiprazole? Thanks.
Well, I mean, we know that in early intervention, there isn't too much difference between different antipsychotics in terms of their efficacy. And I think it's important to recognize that I'm not saying that we should be metabolically minded to the point of not giving clozapine. That is not what I'm saying. I want, where clozapine is indicated, we should be giving clozapine. It's a fantastic, it can be a life-changing, treatment. What I'm saying is that in individuals with first episode psychosis, or individuals who have a treatment responsive illness, I would aim to preferentially use treatments which have more benign metabolic side effects than those that don't. So where possible, trying to avoid using olanzapine, risperidone, quetiapine, if possible. I'm not saying, sometimes it doesn't work. It's just trying it first. The question, but also at the same time, it's about that sort of concerted effort of trying aggressively to manage all the other risk factors at the same time. Unfortunately, that comes down to finances, and EI services are able to do a little bit more than the sort of chronic sort of general adult community teams with this, in terms of sort of walking groups and stuff like that we have in South London. But it's about tackling it all at the same time. With regards to your question about starting metformin prophylactically or similar treatments, the honest answer is we don't know. I know there was a grant application, I'm not meant to know about this, but there was a grant application from Oxford where they were thinking of doing this, of prescribing metformin early in EI services, which I think didn't get funding, unfortunately. If in the book, what we do suggest, we don't go as far as saying, we should be starting metformin early, I think. But what we do suggest is if you see someone who's in the pre-diabetic range is prescribed something like olanzapine, certainly clozapine, then we would suggest starting metformin at that stage, both for its weight loss profile, but also in the sense that we know in the general population adding metformin early delays progression to diabetes. And it makes it easier to persuade the GP to take on that metformin prescription as well, if you say the person's pre-diabetic and we're trying to avoid them getting diabetes, because that's another issue. Another barrier to this metabolic prescribing is GPs not being happy with taking on some of these prescriptions if you're trying to do that. So specifically, some of the newer antipsychotics. So Lorazidone's not been around for a while. Cariprazine, at the Maudsley, you're only allowed to prescribe cariprazine if someone has a predominant negative syndrome, and not for if they have a metabolic syndrome, essentially. And cariprazine, hardly any GPs are prescribing that now. But yeah, sorry. So I've waffled a little bit, but essentially, I think the take-home message is I'm not arguing that we shouldn't be giving clozapine. I really want to get that point across. And to be honest, I'm not arguing that we shouldn't give olanzapine. I think olanzapine can be an incredibly effective treatment. But what I am arguing is that we should be giving the other drugs a go first, and then and rattling through them. And if we think it isn't working, and it's always about risks and benefits in any treatment in medicine. If we think it ain't working, then we move on to the next treatment. And if that ain't working, okay, then we're on to clozapine anyway. So, and then it sort of relates to my answer to Julia, that we're it's about those risks and benefits, but recognizing the significant benefits that some of these treatments have.
So Mike's question, I'll just read it out. Are there good examples of where we have physical health culture, a good physical health culture for mental health services, or integrated physical and mental health care?
A single trust or hospital doesn't spring to mind. I mean, I know there are. It'd be nice to become a bit more orchestrated with our efforts and to have an evidence base for how services should be designed. I know that dotted around the country, there are various initiatives, such as certainly in sort of care of the elderly wards and linking up with older adult services and having that sort of thing. At the Maudsley, I mean, I hate to be one of those people who bangs on about the Maudsley, and I apologise because they're a bit boring, but we do have quite, I would say it's quite an impressive initiative at the moment, where we have this thing called Consultant Connect, where you're able to pick up the phone and speak to a consultant of a given medical subspecialty if you have a question. We've got a great smoking cessation service. We've got a physiotherapist, Brendan Stubbs, who's also a powerhouse in research in his own right, who's busy going into sort of psychiatric intensive care and getting people doing HIIT training. We've got a dietetic service, which is quite well funded. But ultimately, the answer to your question, there isn't a model service, unfortunately, at the moment. And, you know, and having a model service, unfortunately, is going to cost a fortune, and no one's got any money.
Yeah. Thank you so much, Toby. It was a fantastic talk and a really excellent set of question and answer session. The chat is filling up with a few more things, but they're all compliments and thank yous from the audience. That was absolutely brilliant. Thank you very much.
Thank you, everyone, for listening.
Bye.